Our next speaker is Dr. Kianoush Kashani, and he will be talking on albumin and clinical outcomes in AKI and CRRT.
Thank you very much. It is a great honor to be here. Thank you, Ravi, for invitation. I always come here with my backpack empty, fill it up with knowledge, and take it back home. And truly appreciate invitation. So for the next 15 minutes, I was tasked to talk about albumin and clinical outcomes in acute kidney injury and CRRT. I have nothing to disclose, and this next 15 minutes are two sections. One is using albumin as a prognostic marker in AKI and CRRT among adult and pediatric population. Also albumin for resuscitation in a setting of sepsis, surgery, and cirrhosis. We know albumin is a large molecule, 67 kilodalton. We know that it's water-soluble, negatively charged, half-life in normal situation, non-inflammatory situation is about 17 to 20 days, and most abundant protein in extracellular fluid and intravascular fluid is albumin. And in addition, liver is able to generate albumin of about 150 milligram per kg per day. Albumin has a significant number of roles. 70% of plasma oncotic pressure is from albumin. It is antioxidant. It detoxifies by attaching to toxins. It is anti-inflammatory, stabilizes endothelial cells, and also immunomodulatory role is described for albumin. Now, we looked into our data set of about 10,000 patients who were admitted in our hospital with a rate of 16% acute kidney injury, tried to see how albumin is related to acute kidney injury. As you can see, there is a good U-shaped relationship between albumin and acute kidney injury. However, there is some differences. Among patients who had albumin more than 4.5 gram per deciliter, odds ratio of acute kidney injury was more than 2, twice as much acute kidney injury, but majority of these patients had acute kidney injury is stage 1, so mild form of acute kidney injury. Although incidence of acute kidney injury was lower among patients with albumin level less than 2.4, however, majority of them had a stage 3, indicating that low albumin is likely indicator of inflammatory state that is associated with damage to the kidneys. Then we divided patients with cirrhosis and non-cirrhosis patient. Obviously, cirrhosis patient have higher risk of acute kidney injury. Therefore, odds ratio of acute kidney injury was 2.6 versus 1.4 in non-cirrhotic patients. When we looked into high albumin, then there was no relationship between high albumin and acute kidney injury in cirrhotic patients, likely because albumin is used as a medication in liver patients in comparison with patients who are not cirrhotic. This meta-analysis was done by Professor Ioannidis and colleague a few years ago, and they looked into acute kidney injury incidence in about 4,000 patients, 17 articles. As you can see, for each gram decrease in albumin level, acute kidney injury risk increases by 134%. For mortality, among patients who have acute kidney injury, mortality is about 2.5 times more when albumin is lower. So with each 1 gram per deciliter of albumin decline, risk of mortality among patients with acute kidney injury is 147%. Now, pediatric population might be a little different. So this study, a small study of pediatric population, multi-center cohort study between 2016 to 2020, median age of kids were 1 year old, participated in this study, 40% rate of acute kidney injury. As you can see, higher albumin is associated with slight increase in risk of acute kidney injury. In addition, when you look into incidence of acute kidney injury, among those who have serum albumin of 3 or less is about 40%, but the albumin goes higher, around 4, risk increases, the incidence increases to 62%, and then 77% when albumin is about 5 gram per deciliter. When they use albumin as continuous variable and adjusted for multiple variables, they noticed that albumin more than 4 is associated with acute kidney injury incidence increase with odds ratio of about 6% increased rate of acute kidney injury. So this may us think that perhaps in pediatric surgical ICU that they often have single organ failure requiring surgical procedure, relationship between albumin and acute kidney injury could be related to hemoconcentration rather than low albumin level in adult population that indicates inflammation. Now, how about albumin in CRRT patient population? This is a retrospective cohort of about 1,600 patients on CRRT. Obviously, like any other CRRT cohort, about 2/3 of them had died. Mean albumin level was 2.7 plus minus 0.6 gram per deciliter. As you can see, the higher albumin among this patient population was, the lower mortality was. And when they divided albumin based on tertiles, first tertile had twice as much mortality in comparison with third tertile in this cohort. So the other question is that not only based on albumin may actually provide some information for us, changes in albumin may be important as well. This study from South Korea by Dr. Ri and her colleagues it was done amongst patients who were on CRRT for at least 72 hours. They all had hypoalbuminemia, and the size of cohort was about 800 patients. They divided patients into 4 cohorts. One was cohort of patients who had high albumin and persistently remained high. The other cohort, low albumin, persistently remained low. The other 2 cohorts were low increasing, and the other one is high decreasing albumin. So 4 cohorts were defined. As you can see, patients with persistently low or decreasing albumin have significantly higher mortality in comparison with persistently high or increasing albumin. As a matter of fact, in a subgroup analysis for in-hospital mortality, patients who had low albumin but started increasing their albumin had significantly less mortality in comparison with those who had persistently low albumin, even based on different sub-cohorts. In addition, among those who had high albumin, those who had declining albumin had significantly higher mortality, regardless of subgroup of patients that they were in. Higher mortality among those was noted. So changing albumin can potentially have some prognostic meaning. Now, switching gears a little bit to albumin for fluid resuscitation, and we will focus on sepsis first because the data is a little fuzzy in here. Whenever we use any fluid for volume resuscitation, our goal is to enhance the size of intravascular space. We don't really want to increase interstitial volume. And different fluids have different ability to do that. As you can see, crystalloids often, in 1 liter of crystalloid, often increase intravascular space by about 250 to 300 cc's. 1 liter of 5% albumin increases intravascular space by 500 cc's. So 500 cc's of it often leaks to extravascular space, and particularly in the inflammatory setting, when hydrostatic pressure is high, that leakage even increases. The only fluid that stays completely inside the vasculature is whole blood, if patients don't bleed. Based on multiple studies, retrospective studies in the 1990s that indicated albumin may be harmful in resuscitation, a SAFE trial was conducted. After enrollment of 7,000 patients, they noticed that saline and albumin for resuscitation do not change 28-day mortality. So that indicated that albumin could potentially be used for resuscitation. In subgroup analysis, however, those with traumatic brain injury had significantly higher mortality when they received albumin versus those with severe sepsis that had a trend toward improvement in outcome when they received albumin. So because of that, there was a meta-analysis done heavily influenced by presence of a SAFE trial. 7,000 patients undershadowed all the other studies. As you can see, they achieved the statistical significance showing 18% lower rate of mortality when albumin is used for sepsis resuscitation. That instigated a need for additional, better designed clinical trials. Multiple of them were conducted. One of them was Albius trial. After 1,800 patient recruitment, 90-day mortality, as you can see, there was absolutely no difference between crystalloids and albumin in mortality. So further studies trying to dig in and try to find what cohort of patients potentially benefit that. This study looked into MIMIC-3 data set of over 47,000 patients, identified patients who received albumin for resuscitation versus not, and then they did propensity matching. They came up with 750 pairs of patients that received albumin versus no albumin. In a post-match analysis, 28-day mortality was significantly less among albumin group. And this was similar to pre-match cohort. But 90-day mortality wasn't different, and there was no difference in renal function recovery and the length of stay in a hospital and ICU was significantly longer when albumin was prescribed. Next question is that now we don't want to kind of really see what is the difference between using albumin versus not. We want to see if albumin that we are using, should we use it early or later. So this study was designed in order to address that question. And early albumin was defined as less than 24 hours after ICU admission. These are 2,800 patients in the cohort of patients with septic shock with acute kidney injury stage 3. And early albumin was defined in delivery of albumin within first day. 10% of cohorts achieved that criteria. Primary outcome was time to discharge with clinical stability, and they showed that early administration of albumin was associated with 4 days saving length of stay in a hospital, so shorter length of stay with clinical stability. When they looked into other variables, they noticed chances of discharging from hospital is less when you have cirrhosis, you receive blood transfusion, you are on mechanical ventilator and vasopressors, and creatinine at the baseline is higher. But early versus late was associated with 80% higher chance of discharge from the hospital. As you can see, this is a negative and negative picture. So red line is a late albumin, and they had more no hospital discharge. And so patients with early albumin, they had earlier hospital discharge based on this study. Now, we asked the question that based on surviving sepsis campaign, resuscitation should be in the first 6 hours. How about if we consider using albumin in the first 6 hours of resuscitation? Does that make any difference in the outcomes of patients? Based on surviving sepsis campaign, it recommends if you need substantial crystalloid volume, partial use of albumin is suggested. So we looked into cohort of 2,700 patients with septic shock at Mayo Clinic. About 300 patients received albumin. We did a propensity matching, 1 for albumin, 2 for no albumin control, and the primary outcome was ICU shock-free time. There was no difference in shock-free time, and indeed, proportion of patients with shock-free time was higher among those who did not receive albumin, indicating potential trend toward worse outcome among this population. In addition, before matching, we noticed that those who received albumin, they needed more fluids. This is based on surviving sepsis campaign again. This is a retrospective study. Those who needed more fluid, they received albumin as well. So as you can see, in day 1 and 2, there was significantly more albumin received. There was no association of receiving albumin with any other outcome, including acute kidney injury, mortality, length of stay, and so forth. So if I want to summarize what happens in sepsis, is that albumin versus no albumin, it doesn't change mortality much, and length of stay may increase. Early versus late albumin, if 24 hours is threshold among AKI patients, it increases chances of hospital discharge with decreased length of stay. And if it is 6-hour threshold is used, there is absolutely no difference in the two cohorts. Intraoperatively, this is a cohort of patients with major abdominal surgery who received transfusion, 2,400 patients, about 850 received albumin, primary outcome, acute kidney injury, hospital length of stay, and 30-day and the mortality. Acute kidney injury overall and acute kidney injury stage 2 and 3 were the same, even after adjustments. And the mortality was the same as well. And worst thing is that length of stay was longer when albumin was used for resuscitation. Among a cohort of cardiopulmonary bypass surgery, about 1,000 of them, 12% acute kidney injury, propensity matching resulted in 140 pairs of patients, showed those who received albumin actually had significantly higher acute kidney injury incidence. How about during dialysis? This study was done as a post-hoc analysis of renal trial, which was intensity of dialysis association with outcome. 770 patients received albumin, different concentrations of albumin, 20%, 4%, or a mixture. As you can see, it doesn't impact the outcome, nor it does impact the cessation, liberation from dialysis, or mechanical ventilator. This study was done by our chairman and Dr. Macedo recently. It's a crossover randomized clinical trial of patients on dialysis in the hospital that receive 100 cc's of normal saline versus 25% albumin. After 6 sessions, they switched, crossed over to the other arm. 65 patients, 55 of them AKI, 250 dialysis sessions. They showed normal saline associated with significant higher hypotension episode, significant number of need to stop ultrafiltration, 15 minutes longer with no ultrafiltration on dialysis, and also additional need for normal saline during dialysis to manage hypotension episodes. In cirrhosis, albumin is associated with different outcomes. Albumin is not normal in cirrhosis patients. There are some post-translational modification that changes its nature. In addition, ischemia-modified albumin is due to oxidative stress changing N-terminal side of albumin, decreases its efficacy, and also increases chances of mortality. FRIX trial was to assess 5% albumin versus normal saline in about 300 patients. Primary outcome was those who were achieving a MAP of more than 65. The first 3 hours, albumin was successful, heart rate was lower, blood pressure was higher in albumin group, and mortality was also, survival in 7 days was higher, 44% versus 38%. ALS trial, the different question, 20% albumin versus plasma-light. Unfortunately, because of respiratory failure, 11 of the patients in albumin group crossed over to plasma-light group. So they had to do per protocol study. As you can see, lactate, mean arterial pressure, norepinephrine dose, PF ratio, and IVC diameter improved with albumin. CVP didn't. And there was no difference in hard outcomes, including mortality, regardless of type of analysis they did, intention to treat per protocol. So they concluded that 20% albumin perhaps help us to achieve mean arterial pressure more than 65 earlier, decrease time to lactate clearance, decrease number of dialysis, and longer time to dialysis initiation, comparable mortality, and unfortunately more respiratory failure, as we all know. To summarize, outcomes, albumin for prediction of outcomes in adult, albumin with AKI relationship has some U-shaped relationship. High albumin is associated with AKI, and the CRRT, low albumin is associated with AKI and death. Using albumin for resuscitation in sepsis, questionable mortality benefit. In surgical services, increases length of stay. Among patients with dialysis, in CRRT, decreases length of stay. In HD, use of albumin is associated with less hypotension. And cirrhosis patient improves hemodynamics and increased risk of respiratory failure. With that, I thank you for your attention.